My name is Anna Andreu, and in this video, we will discuss with Professor Lars Bendtsen the diagnosis of trigeminal neuralgia. Professor, thank you for being with us for this trigeminal neuralgia campaign of the International Headache Society. So before we start, I wanted to ask you, how long does it take for a trigeminal neuralgia patient to be diagnosed correctly?
Well, this depends very much on the knowledge about the first healthcare professionals that actually meet the patient. If it is, for example, a dentist who has no knowledge about trigeminal neuralgia, then sometimes it can take a long time. But if they meet healthcare professionals who knows that this could be TN, then it's short time. So it's very much dependent on the knowledge of the first people that meet the patients.
Well, and that's why we're doing this series of videos. That's why we're launching this awareness campaign, because our aim is to educate the professionals to better diagnose the trigeminal neuralgia patients. So when a trigeminal neuralgia patient appears in your clinic for the first time, how will you approach them?
What is absolutely essential is to get the patient history. How did the pain develop? Where is the pain? We are looking at all the criteria from the IHS and to see if they fulfill these criteria. And if not, then we should be cautious that it could be not a primary trigeminal neuralgia, but something secondary.
So will you perform a neurological examination, and do you expect to see any deficits during the neurological examination?
We, of course, do a neurological examination, and we know that about 1/3 that can have very subtle sensory deficits, but it's very subtle. If you have a clear-cut, clinically significant sensory deficit, then it's probably not a primary TN.
Okay, this is very important to emphasize. And what type of test will you order for those patients?
We will always order an MRI in all patients, and we do in our center, we do 3 Tesla MRIs, and we have a special TN protocol. And it's we always make our neuroradiologist examine this in a blinded way, so they don't know the pain side, just not to make them biased.
That's good. And when it comes to the protocol, I mean, in general, when a general neurologist orders an MRI scan, what emphasis should they give? I mean, what is the actual scan request they should make?
What they should request is that it should be evaluated whether there's a neurovascular contact, and then it's very important that it is the degree of contact is described, not just contact yes, no, but also whether there's these morphological changes. That's extremely important because we need that for our further decision making.
And what about an MRA? Will you normally order an MRA?
Yes, always. We always do it. Even if they have an MRI already, then we will do it in our own setting because the evaluation of the MRI is very dependent on the knowledge from the neuroradiologist. And there we only trust our own neuroradiologist.
And depending on the outcomes of the scan, how will you then classify the patient, or what type of diagnosis may the patient receive?
Yeah, then we can have the primary TN, which consists of the idiopathic TN, where there's either no neurovascular contact or there's a contact which does not make any morphological changes. And quite often patients, they are referred to us with facial pain. Neurovascular contact has been demonstrated, and then sometimes it is assumed that it is TN, but that is not the case. You know that 70% of healthy subjects, they will always also have a neurovascular contact. But if there's a neurovascular contact with morphological changes, that's much more common seen in TN patients. So what we do is we divide it into idiopathic and then the classical TN, where there's this contact with morphological changes.
And what happens to secondary trigeminal neuralgia?
Then are the secondary, and there quite often we see tumors. It's about 15% of our patients, they have the secondary TN, and MS patients. That's the 2 main groups. We have a lot of MS patients in our clinic with trigeminal neuralgia.
And in those patients, will the approach be different? Will you confirm the diagnosis with an MS specialist? How will you go about it?
If by far the most patients, they are sent to us from the MS clinic. But if we have a TN patient and we see signs of MS, then we will discuss it with our MS experts.
Mhm. And what else can be mistaken for trigeminal neuralgia? This is, I think, the main problem that most clinicians will have in terms of differential diagnosis. Is it TN or is it not?
Definitely, the first thing that comes in mind is dental problems. Quite often the patients, they feel that it comes from a teeth, and they go to one dentist, the next dentist, and the next dentist. And if you're in doubt of that, you have to have the patient evaluated by a dentist who knows something about, who's a TN expert, preferably. And other things that could be mistaken, which we very often see, is persistent idiopathic facial pain, and it can be challenging to differentiate these two diagnoses.
And it can be challenging because in some patients there may be usually a dull background pain, and continuous dull background pain rather than just paroxysmal attacks, right?
Exactly, and sometimes it confuses the doctors with this background pain, but we see it in 50% of the patients that it is this dull background pain. So then they should be diagnosed as patients with concomitant persistent pain.
And what about a small percentage of patients that may have autonomic features like lacrimation or redness of the eye?
Yeah, there we should think about attacks, SUNCT, for example. And we know that in TN, if the first division is involved, then about 30 to 40% they can have autonomic features, but it is very mild autonomic features. It's not like we see in cluster headache or SUNCT. So I don't think it's not a major issue. They will say that the eye will run a little bit. It's not like in the attacks.
But the pain should be mostly in the second and third division of the trigeminal nerve.
Yes, if it's only in the first division, then you should really consider, is this actually SUNCT instead?
Okay. So coming to the end, what would be your message to the clinician and what would be your message to the patient?
My message to the clinician is to be quite be very focused on, is this actually a TN patient or is it something else? We see a lot of misdiagnoses out there, and it has major costs for the patients. And then it is very important that we give the correct subdiagnosis. Is this idiopathic or is it classical TN? Because that is really something that influences our decision making. It depends on when will we recommend surgery for the patient. So the diagnosis is very important. And then it is very important to educate the patient how to manage this pain.
And a small message for the patient?
A small message for the patient is that if you have this facial pain, go to a specialist, because that can be very rewarding. We can actually treat most of these patients, but they should go to a pain specialist.
That's a very nice message for the patient. Professor, thank you very much for being with us today.
You're welcome.